Hello. So in this video we're talking about drugs that can reduce the production of the cerebrospinal fluid, or drugs that are suspected to reduce that production of CSF. To start with, we need to understand a little bit about how cerebrospinal fluid is produced, which is what this diagram is meant to be showing us. So about 60% of the cerebrospinal fluid is produced by the choroid plexus, and it's this fluid proportion that we're going to concentrate on. The remainder, thought to be about 40%, is produced from the interstitial fluid, the leptomeningeal and parenchymal capillaries, and the ependyma. CSF is produced by the brain and the choroid plexus, and the choroid plexus, it tends to flow through the ventricular system from the lateral ventricles, through the third ventricles, through the mesencephalic aqueduct, into the fourth ventricle, and there is choroid plexus in each of the four ventricles. Fluid is then absorbed through the lymphatics, especially the nasal lymphatics, and the lymphatics associated with the blood vessels on the skull base, and the blood vessels associated with the dorsal nerve roots. And as an overflow system, it can also be absorbed through the arachnoid granulations, but of course it's well known now that the arachnoid granulations are not the main site of absorption of cerebrospinal fluid. So, concentrating on how cerebrospinal fluid is produced by the choroid plexus, this little diagram is showing the choroid plexus in the brain, and then you can see that it is this villus structure with this specialized epithelium and a close association with a blood vessel. And I'm not going to go through all of these complicated ion channels. The main purpose of this diagram will be apparent later when we talk about the drugs, but it's really to say that it's a very, very complicated process. There's lots of many channels. I haven't represented all of them on this diagram, and key to it is an enzyme called carbonic anhydrase, which is important for taking carbon dioxide and water and generating bicarbonate and one proton, and this bicarbonate is important for many of the metabolic processes through this cell and ultimately cerebrospinal fluid produced. So the main drugs which are used to reduce cerebrospinal fluid are the carbonic anhydrase inhibitors. And as I've said before, there's several carbonate transporters involved in CSF secretion. We have the sodium-iodine chloride bicarbonate exchanger, the anoid exchanger, and the sodium bicarbonate co-transporter, some of which you can see are illustrated here. And the activity of these ion channels, these transporters, depends on this availability of this bicarbonate substrate. And so if you don't produce enough of this, if you have an inhibitor of this, then it slows the whole process down. It should be said that there are lots of sites of carbonic anhydrase. It's a very common enzyme. It's involved in cellular pH buffering and many metabolic processes, and there are at least 15 isoforms throughout the body, including obviously the brain, the eye, kidney, and red blood cells. And all of the carbonic anhydrase inhibitors will have the adverse effect of leading to a metabolic acidosis, which can make the animal or person feel very ill indeed. So they can have signs of malaise, gastrointestinal pain, poorly functioning bone marrow, become anemic, all sorts of quite vague but nasty clinical signs. And of course, a full-blown metabolic acidosis makes you very, very sick indeed. Therapeutically, the carbonic anhydrases are traditionally actually used as anti-glaucoma drugs. They can potentially be used as anti-epilepsy. It alters the pH of the synaptic cleft. Anti-obesity, I suspect because being slightly metabolic acidosis means you don't want to eat as much. Anti-tumor and anti-migraine. For our purposes, the purpose of this lecture, we're thinking about the cerebrospinal fluid. So it is effective against pressure conditions with an elevated intracranial pressure, such as altitude sickness, idiopathic intracranial hypertension, acute hydrocephalus. And potentially, and this is very much isoform specific, it may be effective for neuropathic pain, cerebral ischemia, rheumatoid arthritis, oxidative stress, and it's really quite a hot topic at the moment, Alzheimer's disease. So what are our carbonic anhydrase inhibitors? Well, the classic one is acetazolamide, and furosemide, although it is a diuretic that works by a different means, and these are both diuretics, it actually can inhibit some carbonic anhydrase. Then we have the antacids, which is very much an off-target effect, a sort of byproduct of that. And we have some anti-epilepsy drugs that have this effect, not their primary way of action, but they can have this. They can also have an off-target effect on a carbonic anhydrase, and that's topiramate and to a certain extent zonisamide. And then we have some novel compounds that I mentioned mainly for completeness here, such as the coumarins and the sulfur coumarins. I'm not going to read all these lists of names out. You can read them yourself. But a lot of these are drugs which are under development, sourced from pathogenic bacteria, fungi, protozoans, and nematodes. It's really actually quite an active area of research, mainly because of the interest in this for some of the hard to treat diseases like Alzheimer's disease. But I should say is what we need is one that is specific for the choroid to be able to treat the cerebrospinal fluid production, and that isn't available as yet. So the most commonly affected drug that is used is acetazolamide, and the dose rate is there should you need to have it. And it actually works by more than just a carbonic anhydrase inhibitor. It also inhibits aquaporin mediated water conductance. We're going to talk about that later. Has some antioxidant actions and can affect vascular smooth muscle, causing vasodilation, which is useful if you do have vasogenic edema associated with conditions like hydrocephalus, which some people will refer to as hydrostatic edema. So its most important use would be in hydrocephalus and raised intracranial pressure. It is useful for treating hydrocephalus in the short term, and that's a very important point. This should say positive response to acetazolamide bolus is very useful for predicting a shunt response. So if you're thinking about putting a surgical shunt in and the animal is presenting with acute severe hydrocephalus, a response to acetazolamide shows you that it's maybe worth pursuing. However, given long term, had no effect on lateral ventricle size in dogs. So this was a study done by this group. And what they did was they took some imaging of the dogs and put the dogs on acetazolamide, and then had the dogs repeat the imaging prior to placing shunts in them. And what they found was that the lateral ventricle size didn't change at all, but that those dogs were subsequently and successfully managed with surgical therapy. And in humans, it's found that in hydrocephalic humans, the long-term therapeutic effect is negligible. So the take-home message with this is it's something that's quite useful perhaps in the short term, but not in the long term, especially as up to 50% of humans will not tolerate due to adverse effects. We don't really have the figure in dogs, but I can tell you anecdotally that many dogs do not tolerate it in the long term. Glaucoma in the short term, not something that is in my specialty, so I can't really comment on it. There are some dogs that will respond to acetazolamide that have paroxysmal dyskinesia. I must admit I used topiramate in those cases in preference for reasons that will become apparent later. And again, it can be useful for some periodic paralysis. So topiramate. It is actually more effective than acetazolamide at lowering intracranial pressure. The dose is up there for those that want it. Has a shorter half-life in the dog, so you tend to have a higher dose, but you may want to titrate up to that. if the dog is having adverse effects. So there were some rodent model studies by Scott and et al., and they found that there was a 22% decrease in intracranial pressure, and this was for oral topiramate, compared to 5% for oral acetazolamide. And they actually found it was much higher increase with injectable topiramate, but since we in veterinary medicine can't really get hold of injectable topiramate so easily, I thought that's not so relevant for us to talk about. And they found no effect on the intracranial pressure from furosemide, amiloride, or oxytracoside. And these are other similar diuretics to furosemide. So they also find in humans that this drug, topiramate, is more effective for benign intracranial hypertension than acetazolamide. And the bonus, since one of the conditions that we might want to reduce intracranial pressure and reduce the production of cerebrospinal fluid, is syringomyelia. Actually, topiramate has some effect for neuropathic pain in syringomyelia. Not as effective as pregabalin for that pain, but it is it is quite effective. So I tend to start with pregabalin, but I may add topiramate. And the times that topiramate is particularly useful are as if you have Chiari pain and you do have bigger ventricles, and you think that having an increase in cerebrospinal fluid pressure might be important. And also the advantage of topiramate is that it does suppress appetite rather than stimulate appetite, and so it's another drug that might not will not contribute to the dogs being really hungry for food. However, topiramate is sedative, and especially when you combine it with other drugs, and so that may be a limiting factor. And that is why I don't tend to use it for very neurologically compromised dogs, because it may be difficult for me to tell whether they are worse because of the topiramate or worse because of the neurological compromise. I prefer, however, topiramate to acetazolamide for other conditions such as the paroxysmal dyskinesias, although my first choice for that drug is always fluoxetine, and that's simply because you just don't get as many side effects with it as you get in acetazolamide. If you want to know more about topiramate, there is a sister video to this detailing that drug in a lot more detail. Inhibits the sodium potassium chloride cotransporter, and also inhibits carbonic anhydrase. And it is often used at this sort of level here. It's often used in some cases of acute hydrocephalus, and the thought that this diuretic will also help get water out of the brain. And older animal studies showed that it reduced the CSF secretion by 20 to 50%. However, there have been these recent studies that have not found any significant effect on intracranial pressure, so it sort of brings that into doubt. One of the reasons I don't use furosemide is that reason for not really knowing whether it's been effective or not, but also because it activates the renin-angiotensin-aldosterone system. And I'm thinking that this particularly in dogs that are prone to mitral valve disease, that giving furosemide early may actually contribute to congestive heart failure. So that means that it's a drug I'd rather not use in any of those breeds that are predisposed to that disease. And of course, dogs that are predisposed to the CSF disorder syringomyelia are generally also predisposed to mitral valve disease. One of the other reasons why I don't like using it is that it causes dehydration and hyperkalemia, but in some cases in acute hydrocephalus management, this would be the dose rate that I would use. We often talk about omeprazole for reducing cerebrospinal fluid production, and it's a proton pump inhibitor, and it reduces activity of the sodium-potassium ATPase pump, which is illustrated here. Actually, there's very poor evidence that omeprazole is useful. These studies here by Giraud over about a 3-year period found that it had poor evidence that it achieves therapeutic choroid plexus concentration, so it's not even necessarily getting to the site, and very poor evidence that it affects the cerebrospinal fluid production. There is some anecdotal evidence of dogs being improved after being put on omeprazole, so perhaps it's worth a 2 to 4 week trial. That it's unlikely to do any harm. Some dogs are nauseous on omeprazole. If they are, it's very easy to stop. What I would say, though, is don't start other drugs at the same time or you can't evaluate. There's so many dogs with syringomyelia that have a diagnosis and they're popped on gabapentin and non-steroidals and omeprazole all at the same time. Yes, there is a value in having polypharmacy for treating this complicated disease, but it's also useful to start these drugs sequentially so you can tell, one, which drugs are having an adverse effect, and two, whether or not they have a benefit. Otherwise, you're just having them on all of these drugs for no good reason. I also think there's a possibility with this drug that you may have a positive effect to start with, but it might not be sustained. So there was this interesting paper which I have at the side that used high dose omeprazole. So this is 10 milligrams per kilogram. It's 10 times the normal dose. And they used it for these hydrocephalic dogs. This was 12 dogs. 50% died in a long-term follow-up. That was a very variable time period in that long-term follow-up, sometimes days, sometimes years. And in 4 of the dogs, where they had the opportunity to measure the ventricles, 4 of the dogs, it decreased in size. This is size here. And that was assessment by ultrasound through the fontanelle. So this is how they did it, made measurements using ultrasound. The timing of that measurement wasn't indicated, so that we don't know if it was very soon after starting the drug or quite some time later. There was no statistical evaluation in that paper either, and in one dog it actually increased in size. So I think it's a very interesting paper. It would be, I'm not sure whether this journal is peer reviewed, but it doesn't come up in the so I suspect it's not. And it would be lovely if it maybe could be repeated and be a bit more vigorous, because it would be nice to get that data out there properly. However, it's a very high dose of omeprazole, this can lead to problems. So this was a Maltese dog that was on omeprazole for years, 4 years, one presumes for the management of hydrocephalus. And then I think because the dog had deteriorated, it was increased to 10 milligrams per kilogram. And the dog had these fundic gland polyps. And so chronic omeprazole certainly has a warning written in the formulary that it can result in chronic gastric changes, meaning that it's not really desirable to prescribe it for more than a few weeks. So that is another sort of downside for perhaps considering long-term omeprazole, that we don't really know what long-term omeprazole is doing to these dogs, and we don't know if there's any benefit. However, saying that, a lot of these brachycephalic dogs that get syringomyelia and perhaps hydrocephalus also had gastroesophageal reflux, and so it may be that the reason why they feel better when they're on this drug is that is helping with that. So it is possibly worth considering as a trial. So then we have the H2 receptor antagonists, cimetidine and perhaps famotidine. Famotidine is not licensed in the dog in the UK, so it's not as commonly used, but it may be your antacid of choice, and you may use that or know about that a little bit more than me. So choroid plexus cells have histamine receptors, as illustrated here. And when you inhibit this, then you inhibit the histamine stimulation of cellular cyclic AMP, which is important with a lot of the processes of creating energy for these pumps. It also has some carbonic anhydrase inhibitory action, and actually famotidine has more action than cimetidine in that regard. It is a potential useful drug. It does distribute into the cerebrospinal fluid, However, there's poor evidence for therapeutic benefit, basically because no studies have been done. Our evidence for this is based on some very old experimental evidence in cats. As I've said before, some of these old studies, like the one in Furosemide, showed a massive benefit, and then when it's been repeated, it's not been proven to be the case. There is, again, some anecdotal evidence. Again, maybe it's worth a 2 to 4 week trial. It is a drug that's given every 4 to 8 hours, though, so somewhat inconvenient compared to omeprazole, which is given once daily or maybe twice daily. Again, don't start other drugs at the same time because otherwise we can't evaluate it. And I have a question there about famotidine that may be more effective. Corticosteroids, they do affect cerebrospinal fluid production, so they're talking about drugs like prednisolone, methylprednisolone, and dexamethasone. They affect the mineralocorticoid receptor on the choroid plexus cells, which is associated with the sodium channel, it's also, corticosteroids have other effects. They're neuroprotective. They protect against increases in vascular endothelial and blood-brain barrier permeability. They suppress inflammatory cytokines and reactive oxygen species. However, if you give in the long term, you will get iatrogenic hypoadrenocorticism and other complications. And I absolutely do not recommend giving steroids in the long term for either hydrocephalus or syringomyelia. Often these are very young dogs, and I think sometimes when people prescribe them long term, they perhaps think the dog is going to have a short life, or I wonder what they think is going to happen after the dog's been on it for several months. Well, what happens is the dog ends up without these benefits because I think they are lost in the long term, and with a lot of problems from Cushing's syndrome. So really, guys, short term only. However, they can be effective in the short term. So methylprednisolone was shown to have a 40% reduction in CSF flow, and the effect lasted about 6 hours. So are there any other options? Well, the kind of elephant in the room is the aquaporin part of CSF production. So aquaporins are water transporting proteins, and I've sort of indicated one here. And you think as they're actually transporting the water, that they would be an incredibly good target for CSF production. So aquaporin 1 is involved with the choroid plexus. There is some evidence, as I've said before, that it may be inhibited by acetazolamide. And aquaporin 4 is associated with the astrocytic foot process and the ependyma. And so it's basically associated with the lymphatic system in the brain. So that is the process of drainage of water through the astrocytic foot processes and ependyma in and out of the brain and into the lymphatic system. There is some evidence that it's inhibited by trifluoperazine. I'm not sure if that's how you say that drug. As you can tell, it's not a drug that I use because this is an antipsychotic drug used to treat schizophrenia. But there is a lot of interest in drugs that might be affecting aquaporins. For example, I would suggest that you read this paper here if you're interested in this, recent breakthroughs and future directions in drugging aquaporins. This rather beautiful diagram shows you all the molecules that are thought to be aquaporin inhibitors. What's actually quite interesting is that this diagram, I haven't put all what these numbers mean, but every one there is in bold. This is a supportive reference, and every reference which is in italic is a reference which challenges that action. And so we have good old topiramate here, and it's thought that maybe topiramate will affect aquaporins, but then some others have said no, it doesn't. And acetazolamide here, the same. So I think that's something to look out for in the future, because it's definitely an active area of research. So where are we? I've rattled through a lot of drugs, said a lot of negative things about many of them. Well, where does this leave us for treating our clinical conditions? So these are my conclusions. So for emergency and very short-term treatment of acute hydrocephalus, for example, if there is a tumour, then there is good evidence for acetazolamide. We have an injectable form of that. that although it's not a great long-term solution, it may be a good short-term solution. And there is excellent evidence that corticosteroids will be useful and also neuroprotective to the brain in that instance. There's some evidence for omeprazole in this. There's a new long-acting injectable preparation that might be quite useful for that acute case that comes in, say, with hydrocephalus secondary to a brain tumour. Should we be doing this high dose? As a one-off, it might not do any damage. I don't think we really know that yet, but that study from Brazil would suggest that that might be an option. Also an option, furosemide, perhaps reserved because of the lack of evidence to a poorly responsive short-term case, and maybe cimetidine. If you're in practice and you don't have injectable omeprazole and you have a dog that's not able to swallow, then perhaps that's something that you can use. Our medical management for chronic hydrocephalus, I have good evidence for nothing. No drugs. I really have found no drugs that will be useful for medical management of chronic hydrocephalus long term that won't give you other adverse effects. There's some evidence for, but adverse effects may limit, topiramate. Have to consider sedation if the animal is neurologically compromised, but if you have a very stable animal, then perhaps topiramate will be useful. I have a suspicion that topiramate's effect on cerebrospinal fluid isn't sustained, but that's only an anecdotal suspicion. And then we have the high dose omeprazole, but we have that caution against the gastric changes, and only one paper that is only out of a few animals. There is poor evidence based on lack of sustained response or adverse effects or both for acetazolamide, furosemide, corticosteroids and cimetidine. So for syringomyelia, again, I have good evidence for nothing. No drugs are able to reduce the filling mechanism in syringomyelia that I have found. I have also sent dogs away on omeprazole or cimetidine prior to having surgical management of Chiari malformation and repeated the imaging beforehand and not seen any change in the syrinx at all. However, if they're painful, then perhaps consider adding topiramate. There's poor evidence, perhaps worth a trial of omeprazole or cimetidine. I wouldn't use both of those together because obviously they're both antacids. And there's very poor evidence and not recommended due to long-term adverse effects for acetazolamide, furosemide, and corticosteroids. And there I'm going to end. I hope you found this useful.